So thank you, everyone. I'm presenting this on behalf of the 4 centers in the MS cohort. So MS is really an important disorder in neurology, and it's a common disorder. Probably 1 to 3 in every 1,000 population have multiple sclerosis. In the majority of cases, the illness will run a relapsing remitting course, where patients will have relapses and gradually culminating into a progressive phase where they accumulate a large number of disabilities, but mobility being one important one of them. You can see on the right side, the illness affects the brain spinal cord, resulting in a number of symptoms. But mobility, leg weakness, is the cardinal feature of this illness. And in fact, if you ask patients what are the most important aspects of disability related to them, walking will be number 1. The way that we assess people with multiple sclerosis, both clinically and in clinical trials, depends on the use of clinical scales. The one on the left-hand side, the one which is used traditionally, a scale called the Extended Disability Status Scale. But also we use imaging and tools like the one on the right-hand side, which is the 9-peg Hall test, a function of upper limb function. The Expanded Disability Status Scale is a scale that goes between 0 and 10, and will allocate really a degree of disability to patients, depends on how disabled they are. Patients will need to come to hospital to have that assessment. We thought we will try to see if we can improve on that as part of the Mobilise-D work, by see if we can utilize a telephone consultation to substitute the need for the patient to come to visit. And although the correlation between the in-person and the telephone EDSS was high, the telephone EDSS was not really sensitive to change, so it's not really a good tool if you want to use it in clinical trials. So mobility outcome measures have been used in the past, and you've seen this graph in the previous talk. But this is really sort of the snapshot of the MS, and you can see that mainly gait speed and count steps have been used so far in the literature, but nothing else. We've asked our patients what aspect of their walking is important for them. And they've told us that it is not the speed of walking which is important to them. It is their ability to walk, to lead their normal life, and also being able to walk safely is more important than other aspects of walking. I'm not presenting a lot of data for obvious reasons, because the data is still coming and we're analyzing it. But what lessons have we learned from Mobilise-D so far? We felt really that we could foster links between various centers to promote further trials. And that was clearly very doable and feasible. We learned that we can use mobility outcome measures in clinical trials, and patients will adhere to utilizing these tools in clinical trials. And you can see that the majority of the patients in the cohort were quite happy to comply and use and provide us with reliable data. We've also already made contact with FDA and EMA in relation to the use of mobility outcome measures in clinical trials, but we have to take the discussions further, probably once the data is matured and once the data has been analyzed. But we also learned really that all aspects of almost all 25 DMOs are important and can be used in the assessment of patients with multiple sclerosis. The next step we thought would be to complete the data analysis, and we're doing that really. We hope we'll be able to do it in the next 2 years. We thought it would be important for us perhaps to utilize the data to try to understand progression-independent relapse activity in multiple sclerosis, which are thought to be the holy grail why patients get worse, despite the fact that we can suppress inflammation in this condition. And of course, we will be analyzing falls data And that came really as a surprise to me because I didn't realize really that patient multiple sclerosis will fall to that degree. And again, there will be further data coming out in relation to that. Beyond the time frame of the study, there's a lot to be done as well. So we would need to continue with our discussions with the regulators. We thought it's important for us to use DMOs as secondary outcome measures in clinical trials, and we've already started that. And Octopus is a trial running in the UK where if integrated DMOs as a secondary outcome measure in subgroup of patients. But we thought we also need to use artificial intelligence also to utilize the huge data set that we have to see if we can model really a change over time and try to get really factors related to prognosis. And then the takeaway message in terms of multiple sclerosis, we thought it is really very important for us to look into using DMOs as secondary outcome measures in future clinical trials in multiple sclerosis, and we hope really that the industry will lead the way in that, because we think really that those outcome measures will probably be more sensitive than the outcome measure that we have at the moment. And in fact, it is probably one of the reasons why many of the clinical trials in secondary multiple sclerosis, secondary progressive multiple sclerosis failed, because really the tool that we were using were not sensitive enough. But it also, we think that using demos will be very important in reaching out to cohorts of patients that traditionally are not being captured in clinical trials, and be able really sort of to run clinical trials in a larger heterogeneous populations. And I just really want to thank not only really all the Mobilise-D researchers, but importantly the patients who really gave us all their times and allow us to collect all this data. So thank you.